We have here the components of the sterilely packed Field Orthopedics Griplasty system. I'll go through them stepwise. First step here is the 1.2 millimeter trajectory K-wires. Number two is the K-wire guide sleeve, followed by the parallel wire guide. Step number three, we have the 1.6 millimeter guide K-wires. Step four is the 2.4 millimeter cannulated drill bit. Finally, we have the T-handle implant inserter with the two anchors included for the thumb and the index finger. Okay, we're going to go through the steps of the Volar Approach for the Field Orthopedics Griplasty system. For the Volar Approach, I use a standard Wagner incision. Incision is located at the intersection of the glabrous and non-glabrous skin. It extends distally about midway up the thumb metacarpal. At the level of the wrist flexion crease, the incision diverts ulnarly and then approximately at the FCR tendon. I see the APL tendon. This is going to be the far radial extent of my arthrotomy, and this is where we will place the blue sutures on the final construct. For now, a longitudinal arthrotomy is made right over the trapezium, and then the soft tissue is sharply elevated. I do find that spending some time at this part of the surgery and sharply elevating as much soft tissue off of this trapezium is incredibly helpful when it comes to excising the trapezium. At the ulnar extent of this dissection, the flexor carpi radialis tendon will be passing deep to the trapezium, and I try to take caution not to damage that, as it can be used as a tendon transfer at the end of the case. I can see the FCR passing deep to the trapezium here. I'll do a final inspection here with the curette distally, and I still see a small piece of bone there. It's pretty easily missed, and if that is interposed between the thumb and the index finger, that can be the source of postoperative pain. Okay, at this point I'll review bony landmarks and identify the location of our initial anchor. The bony landmark that I'm most looking for is here. It's very deep, but it is the articular facet of the trapezium on the index metacarpal. That will be the location of our starting K-wire for the first anchor. So I'll now take the 1.2 millimeter trajectory K-wire. I want to intentionally place this behind my Wheatlander because it's going to be important to drop the hand towards the table. This will prevent posterior deployment of the anchor. If this anchor deploys back here on the posterior aspect of the hand, especially if a patient or in a patient with a thin hand, that can be irritating. So that is placed at the articular facet. I'm going to drop my hand. I'm going to make sure that the K-wire is angled from proximal to distal. The near cortex is thin, and the K-wire easily goes into the intramedullary canal. I can feel a firm stop, posterior cortex. I drill bicortically. Oftentimes, again, especially on a thin patient, you can use the opposite hand to palpate that K-wire. I'm not really able to feel it in this patient. I do want to take the freer at this point, make sure that I'm happy with that starting point. I can also then confirm the location of my starting point fluoroscopically if desired. So this fluoroscopic image confirms that the K-wire is bicortical. This is also the exact trajectory of the first anchor that we're going to place. You can see that it fits nicely under the base of the thumb metacarpal, and then it's going to exit on that posterior cortex where it's nice and thick, which provides stability to the implant. I want to place the parallel drill guide over the first wire. I want to make sure that the sleeve, that the barrel with the sleeve is going over the K-wire. I'll then advance the drill sleeve down to the base. It's critical at this point that our second K-wire, which is about to be placed in solid bone. It's not important the position of the actual drill guide. It can be placed wherever solid bone is palpated. So it appears that that's pretty solid. I'm going to actually confirm that just by touching the K-wire down to the bone, and I can get a positive stop. I want to drill this one bicortically. Placement of the 1.6 millimeter stabilizing wire is going to ensure that when we deploy the anchor, it goes in the pre-drilled hole. You can have confidence when we use the mallet that we're actually placing the anchor where it needs to be placed. So at this point, the sleeve is removed. The 2.4 millimeter cannulated drill is then placed over the 1.2 millimeter K-wire. This is drilled bicortically. The first cortex, again, is going to be thin and easily penetrated. You can feel the stop on the far cortex, and it's important at this stage that we not plunge back into the dorsum of the hand where the extensor tendons are at risk. I perform this step by keeping the drill at full speed and then just tapping against the far cortex. Until it penetrates. Again, I do not want to plunge there. I will now withdraw the drill. Usually that first K-wire will come with it. We'll then remove the parallel drill guide, leaving the 1.6 millimeter K-wire in place. So we'll now deploy the first anchor. It's critical at this point that the index anchor be placed into the index metacarpal. That is denoted here on the T-handle implant inserter by the letter I. There's also a hole within the T-handle. This is the hole that will be placed over the stabilizing K-wire. So using direct visualization, I'm going to place first the K-wire over the guide, and then I want to place the suture anchor in the hole. Just our hand. However, that far cortex is going to be thick, and it will require the use of a mallet and probably a little more force than you first think to get this across. Again, we can be confident that we're placing the suture in the appropriate spot so that it's going to come out of the pre-drilled hole because our T-handle is captured here by our stabilizing 1.6 millimeter K-wire. A few soft taps followed by firm taps until the suture anchor goes through. I'm not as concerned about damaging anything on the posterior side with this component of the device because there's no rotation of a drill bit here, and the end of the applicator is going to be covered by that soft anchor. So I will withdraw here and confirm that I've got solid deployment of the soft anchor on the back side of the cortex. I then want to remove the outer blue shell and take out the sutures from the T-handle. I can now withdraw the entire T-handle. Anchor remains in place. I can assess the stability there, and now I'm going to remove the 1.6 millimeter K-wire. Now we'll continue with placement of the second anchor. This is going to go in the base of the thumb metacarpal. The blue sutures here will be used to deploy an anchor in the trajectory of the APL tendon. We will do that by suturing those through the APL tendon. So for the placement of the white sutures, which is what I'm working on with this anchor, I want to place that a little bit away from the APL. That's going to get the divergent V that provides the stability of this device. So if the APL is here, we'll go slightly volar. This will be placed bicortically. I can confirm at this point, if desired, the proper placement of that K-wire by using C-arm. However, I can also see or palpate digitally back here with my index finger that this is bicortical with the parallel drill guide. Again, just as before, I want to confirm that the barrel of the drill guide, which houses the K-wire sleeve, is going over this initial trajectory K-wire. I'm going to take this down to the bone and confirm that the other barrel is up against solid bone. It's not important where that barrel sits. It will not get in the way of the anchor, so I can place it here, anywhere that fits. In this case, I'll leave it in about that position, and I want to place this stabilizing 1.6 millimeter K-wire bicortically. Again, as before, I will now remove the sleeve. I'm going to over drill the first K-wire with the 2.4 millimeter cannulated drill bit. Stabilizing wire is left in place to serve as a guide for the T-handle. There's a hole here in the T-handle that fits over the top of the K-wire. I then advance the anchor into the hole. It's going to go through the first hole, usually without use of a mallet, although may be required. Now that this is deployed on the back side of the thumb metacarpal, again confirmed by pulling back, I'll remove the outer blue shell and take the sutures out of the T-handle. T-handle is then removed, and the 1.6 millimeter K-wire is then taken out completely. The V of the sling is now going to be advanced down into the wound, the V of the sling all the way down into the hole. These blue sutures are only for suturing into the APL, and they're not useful here for advancing the sling. I will toggle the white sutures. And you can see this, the V of the sling advancing all the way down into that initial hole. At this point, again, I have my system pulling maximal traction on the thumb. I can adjust this if desired, so I always start by placing quite a bit of traction, and I'll go ahead and place a few knots here, but this can easily be untied and the tension can be adjusted as desired. So at this point, I'm satisfied with the position of the thumb metacarpal, so I'm going to go ahead and place a few extra suture knots in the white sutures, and that completes the construct on the white sutures. Now, in order to get the V position of the sling to maximize the strength of the construct and to ensure against dislocation of the sutures out from under the base of the metacarpal, I want to take these blue sutures, which have needles attached, and suture those through the APL tendon. I'll use a horizontal mattress technique. These sutures can also be used to attach a slip of the flexor carpi radialis tendon if desired. Here is the FCR tendon. A small slip of the tendon, or alternatively the entirety of the tendon if desired, can then be transected here at the proximal extent of the incision, can be then transferred and sutured down with the blue sutures to the APL. This provides some biologic support and a third restraint against proximal migration of the thumb metacarpal. In this case, I'm very satisfied with the stability of the construct, so I'm just going to complete tying off of the sutures for a total of about 5 knots for each of these. I'll then cut excess suture. Final inspection here is performed. I can palpate the V, and it's nice and firm up against the base of the thumb metacarpal. Again, extremely stable. A capsular repair is then performed with a braided stitch. Thenar musculature is then reattached, and the skin is closed with a nylon suture.